Rhythm is essence of life and it is embedded in all our lives, and we learn to grow with it unconsciously. So is this heartbeat, which is very familiar and very fondly heard in pregnancy during pregnancy. But some babies are not so lucky. And thus fetal arrhythmia is though rare but a complex problem to handle for fetal medicine consultants. So let us see something about how do we evaluate such fetal arrhythmias and what treatment options we have. The incidence of fetal arrhythmias is less than 1 to 3%, and these will be of various types like premature atrial contractions, atrial bigeminy, ectopic beats, SVTs, supraventricular tachycardias, as well as second degree AV blocks and complete AV blocks. Sustained fetal arrhythmia will predispose to occurrence of hydrops fetalis, cardiac dysfunction, or even fetal demise. Therefore, prenatal treatment is warranted for improving the fetal survival rate. And to reach to an exact diagnosis, M mode helps. With M mode, we can see the AV and ventriculoatrial intervals, the fetal heart rate, AV conduction, and even ejection fraction. But detection qualities may be compromised by early detection in first trimester, unfavorable fetal positions, hydrops fetalis, fetuses with cardiac contractile dysfunctions, and obese pregnant women. Addition of Doppler can help in further defining the type of arrhythmia. Treating these fetuses require a proper understanding of the etiology. Grossly, these arrhythmias can be classified into bradyarrhythmias and tachyarrhythmias, of which bradyarrhythmias could be a transient finding, especially in early pregnancies before 24 to 26 weeks of gestation. In cases of fetal growth recession, this can also be a result of fetal hypoxia, or it can be sometimes associated with congenital structural cardiac disorders like isomerism, TGA, critical pulmonary stenosis, maternal connective tissue disorders, positivity of maternal SSA-RO antibodies or SSB-LA autoantibodies. Sometimes the cause is unknown. However, tachyarrhythmias are because of accessory pathways and re-entry pathways where the conduction beat goes back to the atria and a re-entry circuit is established. So when such a case comes, we should decide what investigations we need to do. If it is a case of bradyarrhythmia, we look at the immunological causes. But if it is an tachyarrhythmia, we look at the maternal fitness for antiarrhythmic drugs. For all these reasons, it is better that these cases are referred to an appropriate fetal medicine unit who will go into details of understanding the underlying rhythm abnormality and think about what the treatment options can be designed for that specific pregnancy, taking into consideration the underlying etiological. Broadly, the bradyarrhythmias are treated by use of steroids and beta stimulants, and a combination can improve the heart rate by 10 to 20%. It will also minimize the damage of the ongoing inflammatory process will be stopped by use of steroids and can reverse the changes of hydrox. Tachyarrhythmia drugs are antiarrhythmic agents like digoxin, flecainide, sotalol, and ametron, and this is called as medical cardioversion, of which digoxin and sotalol are the first line drugs. But if the changes of hydrops have set in, then we need to shift to flecainide and ametron. Again, bradyarrhythmias are treated by giving drugs to the mother, taking an advantage that the drugs will cross over the placenta and get into the fetal circulation and will act. Even in cases of tachyarrhythmias, the drugs are initially given to the mother, but sometimes, if the rhythm abnormality is refractory to administration of drugs to the mother, we need to think about direct intraplacental treatment of the baby fetus, either by giving intraamniotic injections or sometimes an intravascular injection of an appropriate antiarrhythmic agent. And once the rhythm has come back to normal, we maintain the rhythm by giving drugs orally to the mother. How is the prognosis? Fetal arrhythmia has got various types and different prognosis. Individualized treatment and clinical treatment should be determined according to the specific types. Generally, tachyarrhythmias have good outcome. Few may progress to WPW syndrome and need further treatments. Fetal bradycardia has shown limited therapeutic efficacy and early treatments with steroids and plasmapheresis remains controversial. If cardiac structural anomaly is present, then clinical outcome and prognosis of patients are usually determined by the type and extent of cardiac malformation. And thus, appropriate clinical measures should be taken into consideration about outcomes and prognosis. Lot depends upon the initial healthcare provider because prompt identification of rhythm abnormalities and a referral to a fetal medicine unit will go to a long way in saving these fetuses. Not all abnormalities need termination. Medical management of rhythm abnormalities has good success rates and is an evidence of how well the pregnancy pathophysiology be best understood and made to use in transferring the much needed drugs to the fetus. Thank you. So let us see some examples of how successfully the arrhythmias can be managed. And this is a supraventricular tachycardia. Heart is not effectively pumping. It's like developing heart drops. We can see fetal ascites there. We initially tried oral medication for this mother, but it was not effective. So we thought of giving amiodarone intravascularly. So this is a needle which is coming into the cord. We're injecting a single shot of amiodarone. This is called as cardioversion or the medical cardioversion. And we can see the rhythm came back to near normal on day 2. The heart is beating normally. Heart drops will take some time to disappear, and it takes some time. This is the heartbeat after 15 days. This patient was then shifted to oral drug, and the baby luckily maintained its heart rate, and at birth the baby is doing extremely well. This second fetus was not lucky, and you can see the heartbeat which is quite irregular. The heart walls are also thickened, and on retrospective examination this patient turned out to be ANA positive. So this is an autoimmune disorder affecting the conduction, and was put on beta mimetics and steroids, and the heart rate could be restored back to normal. Recently, this patient came with an tachycardia of 239 beats per minute, and you can see another case of SVT with early changes of heart drops. This time, we thought of using flecainide, which is the second line drug, and this patient received oral flecainide starting with 400 milligrams and slowly tapering over to 200 milligrams, and the heart rate by the end of day 5 came back to normal, and this baby is also doing well. So, if we understand fetal arrhythmias properly, it is easy to chart out specific treatment plans for these babies.